We've got Chief Cepetto, Dustin, and Jasmine. Are we streaming?
We are streaming.
Wow.
All right, let's see how many people we got, and we can start this off.
Still showing waiting on my browser, so there it is.
I got it. It's up on mine.
Okay.
Good afternoon, everybody. We have a few things to cover today, but we're going to start out with an update on what's going on with our protocols with Doc.
Great. In the comments, guys, can you hear us okay? Just let us know. And I will pull up a few things in the meantime. Loud and clear. All right. Thank you, Dave. Okay, here's today's dashboard. I'm sure you all know where to find this by now, but if not, you can just Google Florida COVID-19 dashboard. This is updated at noon and 6 p.m. So these are the noontime numbers: 16,000 cases in Florida, 350 deaths. Here in Pinellas, we're at 413 cases. And unfortunately, I think we're at 10 reported deaths at this point. As of the data from yesterday afternoon, there were still about 24 people in ICUs in the county, and about half of those were on ventilators. So that is the impact of the disease for us right now here. There were some other people hospitalized, but that was the ICU counts. Obviously, the number of cases continues to rise around the country. Some people have started to feel a little bit more optimistic that maybe some of our social distancing has worked. I would say let's not get ahead of ourselves quite yet. I think it's okay to be cautiously optimistic that it's working, but I would not take a deep breath or stand down yet. Quick update, we had thought that we had a third case from within our ranks. I'm under the impression now that that was being reported to the wrong or attributed to the wrong fire department. So it was not a Pinellas County Fire Department. So I believe our number is still 2 in Pinellas County in terms of fire and EMS. So that's kind of where we're at with the epidemic itself. We're learning lots about the clinical nature of this thing. There's a lot more coming out about the various subtypes of the virus. We talked a little bit last time and showed all the genetic variations of the virus, but we're now starting to hear more and more about the L and the H subtypes of the clinical presentation of the virus, and also some discussion that those two things are actually the same disease, but on a spectrum, and people actually move from one to the other in some cases. And so the L version is the one that seems to be a little bit less threatening to the lungs, and the H version is when they go into sort of acute respiratory distress syndrome. And there are a lot of people looking to figure out why some people progress to the H clinical subtype and why some people don't. And I don't think we truly know the answer to that yet. But what I am hearing very clearly as a theme is don't let the SAT freak you out. It will be low. There's some discussion that the virus actually impacts the heme molecule on the hemoglobin. And so a distinction between hypoxemia, meaning a low oxygen level in the blood, and actual tissue hypoxia, which may not be as severe. So lots going on related to that, lots still to learn. A couple of other updates from the county. We did, in fact, go ahead and place the order for the finger stick serologic tests. I think it's very important to understand that those are not clinical diagnostic tests. Those are surveillance tests to see what, if any, level of immunity exists within our responder community. And so not to confuse that with an actual clinical diagnostic test. Excuse me. I've been talking too much. My throat is tickling. The other thing is that we are working on potentially finding access to a small stockpile of some medications for treating this in case our community as a whole comes up short. So we are working to see if we can source some of the things you've heard in the news, like, for example, hydroxychloroquine. More to come on that. So I think that is sort of generally where we're at. And since the last time we came together, we've had both a medical control board meeting and an emergency medical services advisory council meeting where both groups endorsed our plans. And so what I think we ought to do is run through again the plans. There will be a medical control directive this afternoon that essentially launches the entire updated set of plans. And then starting at 8 a.m. tomorrow morning, that's Friday the 10th, I believe that's what day it is. Dispatch will turn on their updated protocols to make sure that we keep everybody as safe as possible. And then as soon as folks can get to Target Solutions and get through the clinical stuff, you can use those protocols as well. So again, the medical control directive is supposed to go out this afternoon, and the assignment would be on Target Solutions following that so that you could go through it and make sure you've caught everything. Jasmine, just to confirm, do we have this? We definitely have this recording so we can use it, right? We'll just capture the YouTube stream. Okay, good.
Yeah, absolutely.
Didn't know if
It should. It's posted on Target Solutions at the completion every time.
Right. I just didn't know if you wanted to put the record option on Zoom too, just as a backup.
We could do that. Yeah.
Might be a good idea. Greg, are you available to walk through the universal guidance document? I can throw it up on the screen if you want to walk through it.
Absolutely. Good afternoon, everybody. And so far, we're staying ahead of this pretty well. We had a universal support or unanimous support from the Medical Control Board and from the EMS Advisory Council. What we tried to do is to try to just build some universal guidance of things to do to keep yourself safe and just have kind of a lockstep of how you can run through the universal guidance here. One is, off duty. We have done really well. Of the 400 cases in Pinellas County, about 40 are healthcare workers. As Doc said, our 3 is actually now 2, and both of those were off duty. They weren't work related that we could tell. And so that's very important in terms of we've been very safe through this and doing very well. So please, when you're off duty following the stay-at-home order, use social distancing. Please keep yourself healthy, eating well, getting enough sleep, washing your hands. Kind of funny that you'd see in a protocol us writing those sorts of things, but us keeping you all safe is really key to our continued response in this. If you or your family become sick, follow the exposure plan and report to your supervisor. Also, we've been working on alternate housing for family or for yourself. So contact your supervisor if like a family member is ill and you need to isolate. Start a shift. Follow your agency screening process, standoff assessment, and temperature check. Make sure that you're starting with a clean environment. The crew off-going might have been tired and run all night or something and not fully decontaminated your station, your vehicle, the patient compartment, your medical bags as applicable. So, please use plastic to cover the surfaces in the patient compartment like Visqueen as determined by your agency. And then making sure that there's a Visqueen physical barrier between the cab and the patient compartment. Make sure that you're checking all your personal protective and disinfectants. At this point, we want the primary respiratory protection to be P100 out there. At this point, it's about 90% of fire rescue is already on P100. That is very sustainable for us because we were honestly burning through the N95s and we're going to run out. We've got a safety stock of about 8,000 of those. And so that is very sustainable for us. You know that the P100s we can use for up to 140 hours worth of use. So they should be individually issued. You should put your name on them. Make sure that you're not wetting them, but just damp deconning those with a hydrogen peroxide wipe after each use, that you're logging that use. And then, you know, that's going to make it very sustainable for us. About 70% of Sunstar's use is on P100 at this time. And we were just talking about there will be an addition to this when it gets transmitted, is keeping vehicle operators for Sunstar on an N95 and goggles, make it a little easier to safely operate a vehicle. So follow the PPE ensemble guidelines. Please make sure that you're using all the decon and disinfectants properly. Remember the 1 minute wet time on the hydrogen peroxide. On the good side of that, we've ordered 4 55-gallon drums of 30% peroxide. Of course, we use 3%, so now we have 10 times that amount in gallons. So I think that we're going to be fine in terms of the gallons of disinfectant that we have available. Keep with the standoff assessment. That seems to be going very well. Follow the placard, the 1, 2, 3, 4 now should be part of what you're doing. We'll talk more about the clinical guidelines of following the clinical care protocols with Doc. If you see something, say something. I appreciate a number of you have written an email, sent it up your chain of command. We've gotten it, and a concern, if somebody was doing something unsafe, we've provided feedback to the Agency for Healthcare Administration and Department of Health to go and check out a nursing home. Is everything okay out there? Or an early heads up was related to homeless. And so we were able to get a working group working on that right away. So anything that you see, please let us know. And it's really meant a lot. And there's been a lot of improvements based upon that. At the hospital, EMS Hospital Transfer of Care Plan has been working well. Please let me know of any concerns on that. Please make sure that you're deconning your unit with disinfectants per the guidelines, and then make sure that we're keeping track of disposal. So most of it will be regular trash. Make sure that you're using yellow bag for any items that are going to be retained for decon later. As I was saying, wipe down that P100 cartridge, retain it for your reuse. Make sure that you're deconning your full face mask or half face respirator. And then reuse or discard your N95. By doing all this, we're down to about 100 N95 masks per day. And we were over 1,000. And so that is going to really help us stay safe throughout this. We know that it's hot. We know it's uncomfortable. We know that you're sweating in the thing by the time you get done with the call. But please, for your safety, just keep up all of our diligence on this. I think you can slide down some more, Don. In between calls or end of shift, please bring with you some extra uniforms. Change your uniform to reduce contamination in your station or vehicle. And then, really look at, can you shower and change to street clothes after your shift, reduce exposure to your family. Making sure that you're fully decontaminated before eating, drinking, smoking, touching, or touching your eyes or face. I've watched a couple of news conferences in which they were wearing gloves, and you see them touching all of their personal things. I got to see a few of those yesterday. One was a general and one was a governor, and they had gloves on. They're touching their water bottle and their pen. So just be mindful of, if you're not fully decontaminated, you've got to be very, very careful. Be safe, keep up the diligence. We know that this is a hassle for the long haul, disinfecting and proper use of PPE, but it is going to keep you and your family safe. Back to you, Doc, I guess.
Thanks, Greg. Wondering if Chief Cepetto wanted to chime in on this general guidance at all as well. Oh, I think you're muted, Chief.
Sorry about that. I'm used to being the host. No, it looks really good. Just reading through it, just seeing it. Looks really good. It makes it's all common sense type stuff, but yeah, you're right. It has to be repeated, and it has to be repeated a lot. I really like the disinfectant list that you came up with. That's good. Those would be good things for everyone to reference and to look at.
Yeah. Thanks. Couple of questions already, and comments actually as well, which is that the P100s make it difficult for the patient to hear you and for you to hear the patient. Yeah, we know, but better safe, I think, at this point. One thing that is in the pipeline as a potential thing down the road would be an adapter that allows you to use your Scott mask or your SCBA mask with an appropriate adapter and filter. That still has some work to do before we think it's a workable solution. But if we were to get to that, it might alleviate that if you already have the voice amplifiers there.
So let me give a quick update on that, because Chief Tedesco from Clearwater and David Hudak from my office, they have been true innovators, and through 3D printing, they have engineered a 40 millimeter band adapter that will go on a SCBA mask. And so by doing that, we could cut our number of cartridges from 2 to 1, which would be be incredible for our sustainment. And the other that would allow you to use the in mass voice amplification, so that would help. And then that would allow us to have sustainable mass of the 3M mass for the foreseeable future. We're starting to see that they need some pieces and parts, and they're very difficult to get.
Great, thank you. Next is a placard on here with some reference for how to disinfect or kill virus off of all of our various equipment. So this can serve as a reference to everybody about what the best appropriate way to be cleaning any of this equipment is, so that we can, again, stay safe. And again, this is included as a reference document. Additionally, there's a placard reminding about what the appropriate PPE would be. So you could certainly print this out and post it. And this is updated to include the P100 being the primary method right now. The 1, 2, 3, 4 placard about how we're going to do the initial patient approach remains unchanged, but also really worthwhile to reemphasize that. And I guess I'll pause there for a second in case anybody else from the group here wants to chime in on that, or in case there's any questions.
Yeah, so just to highlight what was being typed over here is they will be MSA and Scott adapters. And yeah, unfortunately, the question about do we have a mask for everyone? We don't. We only have about 70 left in the warehouse. And so that's why we're on, sharing masks. If we ever can get through an order filled, we'd move away from that.
Yeah. Okay, so the next piece we want to go through, we've already presented to the group, but we'll run through it again with just a couple of minor updates, making sure that we've covered everything. This top portion here about the unified command and the general response plan remains unchanged. Remembering that unified command is a fire chief, an EMS chief, Sunstar director of operations, Craig Hare, and myself. I think I got everybody right, Craig?
Yep, I believe so.
And obviously those folks could be rotated at some point when we all get too tired. So that's the general response plan, again, in the top part of this document, in case anybody didn't see it last time. But in general, standard response configurations, addition of COVID-19 special rescue units in certain circumstances. Condition 5 is not anticipated to be beneficial because we want to maintain coordination of all the transport units centrally. but 2 and 4 sound to be potentially useful, and that would be at agency discretion. EIDS tool, we'll go through it here in just a second. And just a reminder that we are still on condition yellow of the pandemic plan. And that means that we're taking all steps that we need to take to mitigate risk and prevent exposure while trying to provide the best care for our patients as possible. And again, means that there has not been any significant change to the standard of care for our community. Moving into the dispatcher call screening, this is really unchanged. This is what's called the EIDS tool, or the Emerging Infectious Disease Surveillance tool. This is built into the software package that the dispatchers use, and it prompts them to ask certain questions. We have some questions that are tailored specifically to our local options. But other than that, this is something that's used widely by 911 call takers across the world. So the only revision here is just the elimination of one duplicate question that was kind of redundant. Important to mention again that travel history questions are no longer required because there are certainly plenty of cases right here. You don't have to go anywhere to acquire this virus, and that diarrhea is added to the symptom list. And the other thing to point out to you is that respiratory isolation precautions is the only speed note now. No more COVID-19 notes or special respiratory stuff. This is the note. You need to key on this note as a heads up that you need to take precautions. But again, remembering that the note alone is not enough. You have to do your standoff assessment, and you have to make sure whether or not you think there's any chance that this is a COVID patient. Another interesting thing here is we are asking facilities and even individuals to come to the front of the building or the entryway of the facility for handoff, almost similar to how we're doing at the hospital. Again, we want to try to minimize, where possible, crews going in and out of facilities for infection control reasons. This may not always be possible due to what's going on with the patient, but in general, a large number of our residential care facilities were supportive of this. So the dispatchers will give these instructions, and then we'll ask them to put a note in as to whether or not the facility said that they would bring the patient out. So you're not wondering whether the patient's coming out to you or you're going in. We're also asking them to advise the facilities that you all as responders are screened daily, and that you will be in PPE, so not to be surprised. And that's to help them with their requirements that the state has given them about screening people before they enter their facilities, and to help the public not be surprised when you show up in a P100 mask and all the rest of your ensemble. Additionally, this is the response matrix for the 36 card. The 36 card takes the place of card 6, 10, and 26. That's chest pain, difficulty breathing, and sick person, because that's where most of the calls for this come through. And then it adds some of the emerging infectious disease questioning to that and kicks us out a determinant. It is useful to know that if they have no infectious disease positive responses, that it would kick them back to a regular chest pain card for a regular response and regular instructions. So it's actually very nicely integrated. And the dispatchers are all teed up to start using this tomorrow. So you may see 36 determinants starting tomorrow. As you can see in condition yellow, we still get a full normal system response on everything. So it will not change a run card or an assignment at this point. Anything additional would be on top of normal response. I'd point out that if a COVID-19 special rescue is assigned to a call that you're on, we would accept a system unit canceling off that call with a COVID-19 SR en route for an alpha call. But for a Charlie or Delta call, we really want you to get eyes on the patient first and make sure they're not in any extremis before you cancel off to a COVID-19 special rescue. A couple of notes at the bottom. There's no Bravo or Echo determinants on this card, so they're not in the response matrix. We do have the same safeguard we have in here about if anticipated initial response time is 20 minutes, we would go ahead and make sure that additional resources are sent if they're not already. Again, in category or in condition yellow, this isn't really an issue. This would be when we get to condition red. And I think that's the significant pieces in the dispatch protocol. So I'm going to stop share for a second, and I'm going to see if we've got any questions about this. So we're still talking about decon and chemicals and masks. So I think Craig answered that question in the comments. And Dusty says Pasco is now calling viral alerts into hospitals for the patients that answer yes to any screening question. Could we implement this? It would be a heads up. Yeah. So we absolutely want you to give early notification to the hospital if you're bringing somebody in with respiratory precautions. That's key for their process. That's key for facilitating the handoff on the front ramp or at the ambulance bay instead of having you guys go into the hospital wherever possible. So yes, please go ahead and do that. We're not calling it an alert necessarily because that implies some different stuff like strokes and STEMIs. But just in your regular calling into the hospital, if you would please make sure that you say that this is a patient that you have in respiratory isolation precautions.
Let me tag on to that one, Doc. So in that EMS hospital plan, it asks that you give a heads up to the hospital 10 minutes out. And remember that you can do that on your portable radio from the scene. Lieutenant or somebody outside can go ahead and give a heads up if you're down the street or somewhere nearby.
Sure. Great. And then for Adam, can you clarify whether we're dressing out in full gown for every respiratory isolation or doing a 6-foot standoff, even if the speed note is there? So I'll answer that in two parts. The 6-foot standoff should be done on every single patient that you approach. We want to make sure that you are safe. We want to make sure that you are taking a minute to assess the patient, to ask them some questions about their symptoms, and to try to get an impression as to whether or not you think that they may be a COVID patient. And if you think that they may be a COVID patient, then you need to put on the full ensemble. If there's a RIP note, we've already put them through a bunch of questions and determined that they may be a COVID patient. So if you have a RIP note, at least one person needs to get into full PPE from each unit, and then the two of those folks in full PPE can do the transport of the patient to the hospital. So Adam, I guess I'm trying to answer you as clearly as I can. Full PPE, gown, the whole thing for every respiratory isolation RIP note, yes. Standoff assessment on every patient, yes. Upgrade to the full if on your standoff you have any concern that this is a COVID patient, regardless of the RIP note. And any time that you're going to be doing a aerosol generating procedure, an airway management, or working a cardiac arrest, it should be full PPE. Those are all the times you got to get in full PPE. On every other patient, that would be somebody with no RIP note, your standoff assessment doesn't raise any alarms, and you're not doing any of those procedures we just talked about. It is a P100 full face, a P100 half face with goggles, or an N95 with face protection as your baseline PPE for every single patient encounter, even when you don't suspect COVID. Chief Bessler.
Yeah, I'm just kind of writing back that we are working on the due diligence on that for OSHA and NIOSH compliance on that proposed mask. There is some general things that have come out from CDC and others on allowing exceptions when there isn't PPE available.
Yeah. Okay, so again, let's get back into the document about how to keep everybody safe. So this is the general approach to the COVID patient. Again, the goal overall is to minimize unprotected exposures, to keep you all safe. So the standoff assessment is every patient greater than 6 feet away from the patient and in any bystanders. And you should certainly be in minimum respiratory and eye protection at that point if there was no RIP note, and you should be in the full ensemble if there was a RIP note. And then you're going to use the isolation precautions taken intervention to document the PPE used as well as the PPE employed by each person in the crew section. The reason that documentation is so important is so that we can know how much of this stuff we're using, and so we can continue to work to make sure that you have enough available to you. I'm sure you've heard what's going on in other places where they are running out of PPE, and there's a lot of people working really hard to make sure you have enough, but you got to document what you used, and it's got to be accurate so that we know where we stand with this stuff and we don't get surprised and not have enough. Again, here's the things you want to be looking for during your standoff assessment in terms of who might have COVID. Here's the list. Okay. Regardless of dispatch notes, travel, or contact history, any one of these things should also be triggering your concern. We want to limit the number of clinicians approaching the patient. That's where that 1, 2, 3, 4 placard comes into. Follow that placard. That's designed to limit the number of folks that have to be in PPE and be up close with the patient. Again, what the acceptable PPE is here. And we want to, again, protect family members. So no riders in the ambulance unless they're one of these exceptions. So that's a single parent accompanying a pediatric patient or a home caregiver if needed to manage devices en route. And we should be putting surgical masks or a procedure mask if you don't have a surgical mask on those patients to help them keep their germs to themselves. So that is the general approach to suspected COVID patients. I saw another systems recently version of this, and instead of this red line up here where it said goal minimize unprotected exposures, it had the name of their medical director and quotes and said slow down. So, I think it actually conveys kind of the same message is take a second here. Okay? Make sure that you're being safe. Make sure that you're doing a size up on this patient, a standoff assessment, figure out what it is you're about to walk into and keep yourself safe.
Those I think, Doc, have gone really well because the first few days we heard a number of different stories where crews got themselves into something, the patient lied, the caller lied, all of a sudden they're in the middle of it. We've heard, knock on wood, 0 of that here lately. So I think that's going well. There was a question, Doc, from Bob Lanu about any of the COVID questions in EMD would trigger the RIP notification. I answered, I think that's yes, correct?
Yeah, that's correct. Any single positive answer will trigger the RIP. There's a technicality in there depending on what condition you set in the software. Sometimes it can be 2, but we have it set at the most sensitive so that any particular one will trigger it.
Hey, Doc.
Yes, sir.
Hey, just to go back and reemphasize that again about the unprotected exposures. Also the equipment, and I think everyone's doing a lot better job now, and we're kind of getting this. It's kind of unfortunately getting to be the new norm. But protecting your equipment as well, the shuttling of stuff back and forth sometimes, everything. But what's happening is these calls are taking 3-4 times longer than they normally would, and that's getting to be an issue. So that's a really good point to protect not only us and protect our equipment, which we can take it back with us as well. So.
Yeah, that's a great point. And thankfully, our call volume is still relatively low, but it's starting to creep up again over the last day or so, I think.
Yeah, everybody's still home, and we don't have the normal amount of calls.
Yeah, I mean, my shift in the ER yesterday, it was a little busier than it has been over the last week. So I do think we may be starting to see just a little bit of a pickup again. All right, any other questions on here? Looks good. Okay, so let's move on to the clinical piece of this. And again, we've gone through this stuff before, but there's a couple of minor changes, and I want to take the time to go through it again. Since it's actually going to go into effect starting at 8 a.m. tomorrow. Again, I apologize for the delay in getting this all together, but things are changing quickly. We do want to continue writing suspected COVID-19 or confirmed COVID-19 in the EPCR. There's going to be an EPCR update coming as well about some impressions that include suspected or confirmed COVID, and also some of those screening questions in the EPCR to help remind you what you need to be asking about for these patients. So that's all coming as well. General protective actions, again, it's sort of all the things that we've talked about already, but your standoff assessment, making sure that you've got appropriate PPE on, limiting the number of clinicians involved in care, not bringing a lot of personal stuff on the calls or into the trucks, double gloving for aerosol generating procedures so that you can take off the first set of gloves with your gown and still have the second set of gloves to remove the rest of your stuff. Surgical or procedure masks over the patient, with any oxygen underneath the mask, so a mask on top. There's actually another study that just is being about to be published, I believe, showing that that makes significant difference in keeping the aerosol in and keeping the virus in, so that's important. Wrapping the patient up in the blanket, limiting non-essential people away from aerosol generating procedures, etc. Also using the exhaust fan and the AC in the cab to keep air moving away. Clinical pearls, again, these are pretty much the same. We talked about the happy hypoxia. There's more mechanisms being proposed for why this is happening, but it is certainly a thing. I saw one doctor say the other day that she intentionally avoids looking at the SAT until she's already looked at the patient because she doesn't want to be biased by the low number. And so there's really a disconnect between what the numbers look like and what the patients are tolerating. And so really need to focus mental status and fatigue with respiratory effort on decisions regarding moving forward with more aggressive airway management. Temporizing with supplemental oxygen and permissive hypoxia is clearly now becoming the best strategy and should really be our focus in the pre-hospital arena. I haven't heard too much more about the airway edema, but a little bit. So anticipate that these may be difficult airways. Again, hopefully we won't see a lot of particularly ill pediatric patients. So we will be trying to preserve the normal standard of care for them as much as possible. This is going to finish up the last little bit of these pearls, and then we'll get to a couple of the questions that are in the chat room. Best practices, again, remain changing rapidly. We will do our best to keep up with it and to keep you up to date, but things really are changing quickly. And again, the overall approach here is that disaster standards of care are dictated by risk-benefit ratios and the availability of resources. So we are currently in condition yellow. We have a risk, but we have appropriate PPE. We have appropriate resources. The system is not overtaxed. The hospitals are not overtaxed at this point. And so really condition yellow warrants risk management in that way. And rather than a decrease in the standard of care. When we get to condition red and hopefully not condition black, then at that point, a change or a decrease in the standard of care would be reasonable. But for right now in condition yellow, we really want to maintain the standard of care and do everything we can for risk management. And again, it's worth mentioning that we also need to not have tunnel vision on the COVID. We need to make sure we're addressing the other issues that are going on with these patients and to make sure that we continue to treat any non-COVID patients the same way we always would. So let's pause there for a second and look at the comments. I think got a couple questions about the P100s. So people are still working through how long you can use them for. Adam says, what do we do for peds that meet ISO requirements? Surgical masks are quite large for them. Are we okay to forego it? I would prefer you have a mask over the patient if at all possible, Adam, even if you have to kind of fold it or make it smaller. It's does a lot actually to cut down on your exposure risk. So I would still try to do it, but we'll throw on the list to see maybe if we can find some smaller ones.
Doc, can we tape it around their head? Is that okay?
Coban, right?
Yeah. Why not?
No, let's not do that. That's like tourniquets around the neck. Bad idea. Okay. Next one is the RIP note can be scrolled out of view on the CAD. Any thoughts? The call upgrade similar to cardiac arrest. So the RIP can be quickly identified on the call screen.
I'll take that one back to radio and technology and see if they can do something on that.
Great. Thank you. So Mike Elder's talking about how to do the concentration of bleach. I'll leave that to other experts. Looks like.
Well, I will say that that's St. Pete specific, and it is 3.5 cups. So we could check back on that with Chief Gansey or Chief Bassett.
Great. Okay. I will go ahead and continue through the clinical piece of this then.
Oh, and then Chief Menino had a thing about the 140 hours on the mask. Yeah, that's primarily for planning purposes or just making sure that we get some eyes on those.
Awesome. Okay, so here is the adult side of the yellow condition, yellow COVID-19 specific clinical care and provider risk management guidance. And again, we're in yellow, so it's about COVID specific clinical care and risk management, not about altering the standard of care. There will be, hopefully these will get laminated and put out with adult on the front and pediatric on the back. Destination, we want to take COVID-19 patients to the closest appropriate hospital to minimize the time that they're in the back with you. We want to limit fluid resuscitation. We're hearing a lot that excessive fluids cause rapid respiratory deterioration. So limit those fluids under the sepsis protocol to a 500 ml bolus, and then move to early epinephrine if there's, early norepinephrine if they're still hypotensive. Solumedrol, again, we hear that this may be harmful, so we want to defer that decision to the hospital. So skip the solumedrol, and then the filter between the King and the endotracheal tube and the Untitled CO2 filter line set, we'll get those out just as soon as we can. Supplemental oxygen, again, is going to be our very main strategy for these patients. Their SATs may be very low, so supplemental oxygen is where we should be starting. If you can get them to 85 and they're looking pretty comfortable, fantastic. So don't feel you have to keep turning up the nasal cannula or put them on a mask. If you can get them to 85 and they look okay clinically, then I think you're good there. Obviously, the higher flow you do, the more potential risk for exposure there is. So if you can limp them in at a SAT of 85 or 87 on 3 or 4 liters nasal cannula, that's probably about the best thing for these patients. Sitting them up, I'm hearing today, may help as well with their oxygenation, so consider that. And again, we'll keep bringing you those pearls as we get them. NEBs are going to be high risk on these patients, so we want to try to use an alternative wherever possible. If the patient has an MDI, grab it, use it, 2 puffs every 3 minutes to a max of 10 puffs, and then bring that NEB to the ER so that they can use it in the hospital as well. There's not a lot of those things around. The hospital also wants to avoid the NEBs if they can, so bring that MDI to the ER, please. If you need to, you can go to epinephrine in these patients if they're really in extreme distress. Again, with older folks, be prepared and cautious about that and prepared for potential cardiac complications. Suction, CPAP, and BVM also all very high risk, so we want to try to avoid their use if at all possible. They're not explicitly prohibited, but for the sake of safety, you really want to avoid their use. If you do end up deciding to use them, please, please, please make sure that you are in the full PPE ensemble. And if it were me, I'd prefer a P100 at that point. So if we get to the point of needing a BVM, we ought to be considering moving very, very rapidly to getting a tube in to help contain the virus coming off with the ventilations. So the best way to do that would be to get a King tube in them as quickly as possible. That's the lowest risk for us. And if you need to use facilitation meds to make that happen, the way you normally would use facilitation meds for an endotracheal intubation, that will be allowed. You don't need to consult for that. You can just go ahead and do it if you need to do it. Endotracheal intubation, again, also very high risk to us. So we want to avoid if possible and prefer the King tube that would minimize our exposure. If it gets us where we need to be and it's much less risk to us, then I think that's a win. Crike and CPR, again, also very high risk. We are currently in condition yellow, and I have briefed all of the online medical control physicians to be expecting that you may consult them early for cessation in a suspected COVID-19 patient with cardiac arrest. So they will not be surprised by that. And that's going to be a judgment call that you and the doc are going to make together based on the risk-benefit stratification. So I'll pause there for any questions on the adult condition yellow clinical guidance. And Josh, I'll put the curve back up later. Just keep reminding me. So Anthony says, I understand that these are COVID specific, but it would be safe to withhold Solu-Medrol on all respiratory patients since respiratory is an indicator of possible COVID. Yeah. So if you think that, this patient may have COVID and respiratory distress is one of those things that could be, then you would withhold the Solu-Medrol. I don't want to take it off or explicitly prohibit it, because if you have somebody with an anaphylactic reaction, I want you to give them the Solu-Medrol, and that probably has nothing to do with COVID. So if you're going down a pathway where you're in full PPE, you're treating this as a potential COVID patient, that would be the time that you would apply this. And Adam says, confusing with the breathing treatment, are we using our meds or theirs? So we would try to avoid using a neb, and have a strong preference to use an MDI if the patient has one. We do not have MDIs, but if the patient has one at home, the albuterol puffer, use it and bring it to the hospital. And the 2 puffs every 3 minutes is how you should use their MDI. So this is you essentially assisting them with their own medication. The epinephrine obviously is ours unless they happen to have an EpiPen, but even then you probably just want to use ours. Hopefully that answered your question, Josh. And Adam, say so if it didn't. So I'll move on to the pediatric. Again, the top part is pretty much all the same, except for obviously we have our pediatric dose of fluids instead of a small adult dose. This would be a small pediatric dose. And we don't have, oops, that's a typo right there. We're not going to be using pediatric kings, but pediatric endotracheal tubes should get a filter on top of them. Same oxygen general strategy for these kids. So again, this is anybody you suspect might be a COVID-19 patient. This is what we want to do. This whole section about supplemental oxygen and nebulizers, bronchospasm treatment is the same as the adult, except for the epinephrine dosing, obviously, is per the Hantevi book. The albuterol MDI, kids tolerate that super well, and I'm not worried about giving them a bunch of puffs of that. Worst case scenario, they get worse tachycardia, but depends on the size of the kid and how they're responding to it. Suction BVM, again, is the same, minimize use wherever possible. The strategy for these folks really needs to be to try to limp them in on supplemental oxygen if at all possible. It should really only be when their respiratory work of effort is showing them to be really tiring out, or when their mental status is starting to change, that we're going to push forward beyond the supplemental oxygen. Here's the change on the cuff for the pediatrics. So normally we don't inflate, but in this case we would. And Crike and CPR, again, are also extremely high risk for these patients. So you could consider an online consultation for early cessation in a COVID-19 patient. Okay, any questions on the pediatric yellow or any of the clinical issues so far? Keep throwing the questions up there. We want to make sure we get everything clear as much as possible. So this is red. I'm going to go a little quicker through this because we are not currently in red. And so I don't want to confuse what we're currently doing with what we have planned for the future. So if we get to red, we anticipate we will be in system status management. We anticipate we will suspend first pass quality measures and allow the MCI disaster overall exception reason. Solu-Medrol should be stopped really for anybody at that point that you think has anything related to COVID. And so it's sort of the same, but because we're in red, it's more of an alteration in the standard of care as opposed to a clinical pearl or a best practice. The filter remains the same. This all remains the same. Albuterol nebulizers, if we're in red, will be actually prohibited, just as CPAP will be actually prohibited. But the strategy remains the same. Supplemental oxygen to get them to where their respiratory effort is okay. And as long as they're able to limp along like that, we really don't want to get going further. If we have to, we want to get a king tube into them as quickly and safely as possible, and then use that to temporize them to the hospital. Also in condition red, we will prohibit intubation or crikes on suspected COVID patients, and we will only attempt resuscitation if our initial rhythm is VFib or bystander CPR was in progress, and we'll consider cessation after just 3 rounds of shocks and epi in those patients. Red pediatric looks very similar, but some of the prohibitions against airway management, needle crike, and CPR are a little bit looser for the pediatrics. Again, we want to try to give them the best shot, but also we do not expect to see a lot of really sick COVID-19 kids, knock on wood. Okay, condition black. Again, things get a little bit tighter. And one thing to note up here at the top is that if we do get to condition black, it will likely be that nearly all of our patients are suspected COVID-19 patients. And so this becomes a much broader alteration in the standard of care that would likely be approaching all of our patients the same way. In that scenario, we would not work cardiac arrests, and we would essentially do the supplemental oxygen, a couple of meds if we needed to, and take them on into the hospital. So it's all pretty much the same, just you can see the prohibitions on some of the more invasive, risky, and high resource utilizations are significantly higher. And that's because in condition black, the system is completely overtaxed. It's on the verge of failure or collapse. And so we're really trying to, at that point, do the most we can with the limited resources we have left, and not over dedicate resources to a particular patient. All right, so a couple of questions. So we are going to encourage people to make up laminated copies of the yellow card and put them on the truck. And this will be, Dusty, this will be in everybody's Target Solutions very shortly, along with the medical control directive. Lawrence says, how early is early cessation? Is there specific minutes when we should begin consult? No, I don't want to give you a specific on that, Lawrence. I want you to use your judgment about what's in front of you. There may be some patients that are younger or that have other things going on where you might want to give it more of a shot, and there may be other patients where you might want to give it less of a shot and minimize your exposure. And that's why I think it's important to have that risk-benefit discussion with the online physician and make that decision together. So if you'd like to get the doc involved in the code very early on, that's fine, and together you guys can work through how much energy, effort, resource, and potential exposure we want to, or we think is appropriate to balance that risk-benefit decision making. So no, I don't have a specific minute, but I think together with the online doc, you should be able to work through that. Will this be on the EPCR? Yeah, I'm sure it'll be posted everywhere we normally post these things. But remember, Adam, that you don't necessarily want to have your EPCR at patient side with these folks. So it's probably worthwhile to have a hard copy as well, and to have a good idea of what it is. Is the MDI specific to albuterol or Duonev not once daily, i.e. Spiriva? That's a great question, Anthony. Yes, I'm talking about an albuterol MDI. I'm not talking about any of the steroids, Spirivas, or any of those other non-rescue inhalers. And I'm going to actually write that down to see if we put an asterisk there. Great. Next is, if we get to condition red, will a lot of those changes to emergency transports to hospital? Dusty, I'm not sure I totally follow your question. If we go to red, we're going to be on system status management, most likely, and we're going to be steering patients and distributing to hospitals as best as we can to keep the system moving. Um, Driving emergency, I'm not sure we would change a standard on that. I mean, we know that's a risky thing to do, particularly if you're trying to be in PPE in the back. So I'm not sure that, and we also know it doesn't buy us a ton of time in terms of minimizing your exposure. So I'm not sure I could justify saying they all have to go lights and sirens, but I think we would try to make as short transport distances as possible using system status management. Anthony says, what if the patient's MDI is expired? Another good question. I believe the public health emergency declaration from the state surgeon general and the governor's executive order allowed us to be a little flexible on that. But if any questions, I would say just call the online doc. Josh says, is it possible for us to get MDIs? No, we tried, can't get them. So that's why it's so important to ask the patient if they have one there that we can help with. So I'm not sure I can officially on the air, Anthony, tell you to use an expired medication, but I think we do have a little leeway right now. All right, so that is the end of the clinical section. So I'll just take a second there and ask Jasmine or Chief Cepetto if they want to make any comments on those pieces of this.
I'll jump in quick. I wanted to say that just a quick reminder, we talked about this last time, that we are very focused on COVID and we are talking about it twice a week. So prepare your questions. It's great if you have questions and we want everybody to be informed, but we still want to make sure that we're not getting tunnel vision. And we remember there are other patients out there that have other complaints and we don't miss those because we're tunneled in on this.
Yeah. The only thing I'm gonna tag in there is when in doubt, call back control. Lots of changes happening here, lots going on. Please call med control and let that online doctor help guide you through some things if there's any question at all. Yes, we need to have hard copies of this on the trucks for everybody, but use that resource of calling med control. Put the pride away and just call them help you through this stuff.
Thanks, Chief. Okay, James says, early on in the video, you specifically said the RIP note was not enough and we still needed our doorway assessment. Correct. I do not want you guys relying on what somebody told the dispatcher to keep you safe. I want you to do that due diligence yourself and have the ability to make yourself safe depending on what you find there during your standoff assessment. And do we have the ability to make the clinical judgment to downgrade the PPE regardless of the note? Well, as I said last time, I suppose that's something you could do. You are responsible for your own safety. We're providing you with the equipment. We're providing you with the protocols and the procedures to try and keep you safe. If you choose to say that you don't think you need to use it on that particular patient, I suppose you could do that. I'm not sure I would recommend it. Chris says there's not too much a patient can say to make me take my PPE off. I'm right there with you. I have PPE on every single patient encounter at this point. I may or may not have the full ensemble, or I may have the baseline that I've asked you guys to do as well. There is nothing a patient could tell me right now to have me take my respiratory protection off, I don't think.
Yeah. Hallelujah, Chris. I mean, you got to use it, and we got to keep ourselves safe. Remember, you're taking this back to your family
and the rest of your crew potentially.
That's part of your family,
right? So I think for everybody's sake, judgment and caution is the operative thing here. Look, this is a bad disease. This is not just old people getting sick. We need to be real clear about that. There are 20 and 30-year-olds who are dying from this disease, and healthy people who are dying from this disease. You heard a lot about elderly people and underlying conditions. I got to tell you, This thing seems to like to make any different kind of people sick. This virus is acting strangely and doing things that we don't fully understand yet. And I can't see a good reason why you would choose to not avail yourself of the resources that a lot of people have spent a lot of time, a lot of effort, and a lot of money making available to you.
Also, going back to what we were talking about at the beginning, I see a lot of fear out there for bringing this home to your family. So I want to reemphasize that if you bring clothes to work with you to change into before you go home, I know a lot of departments are asking people to do that, but it's your choice really at the end of the day to make sure when you get home that you take your boots off outside and that you're doing the right things so that you don't expose your family. So make sure that you're taking those precautions. I know that people are nervous. We are giving you the guidance so that you can safely go home to your families at the end of the day. So if you go back to the beginning and you look at the things that are going to be coming out today on Target Solutions, you can see some guidance on there of things that you can do to prevent that.
Great. Anthony, what do you mean from the nursing facility working group? Was there a specific question, or is that group still working? Because yes, that group is still working. Oh, yeah, good point about the asymptomatic while we're waiting for Anthony to clarify his question. I'm seeing, initially we said maybe 10, 15, 25% of people asymptomatic. I'm seeing numbers now, maybe up to 50% or more could be totally asymptomatic, which again is making this virus incredibly difficult to control from an epidemiologic standpoint. So I think two assumptions are important right now. Assume that everybody you come in contact with has the virus and could give it to you, and assume that you could give it to somebody else and act accordingly. Anthony. Okay. So maybe let's keep moving while we wait for him to clarify that. Craig, do you want to walk us through the hospital handoff thing again? I'm going to share it up.
Sure. Yeah. This has been out for probably almost 2 weeks now. Very few problems with it. I think most of the hospitals are pretty well working through this now. Baycare of recent is requiring a surgical mask all the time if we're not in PPE. So we are screening at the beginning of the shift, and if not, we should be wearing a surgical mask. 10 minutes out on the radio call, we didn't want to, make it, one more thing to remember to do by making an alert or something like that. But if you would just, remember you can call from your portable radio before you load. And most all patients are going to be transported on the ambulance ramp or, vestibule or entryway. So all except for behavioral health, cardiac arrest, STEMI stroke, and trauma alerts, and those will be to the nearest treatment room. We want to make sure we're not interrupting good patient care on those patients. So remember, just continue the nebulizer treatments, and if you have a CPAP running, to make sure you cover the patient's head and chest to minimize the spread of droplets, and then quickly to the nearest treatment room. So we'll physically transfer patients outside, give a verbal report, and then keeping in mind, we kept reminding the hospitals that they were kind of freaking out that we look like hazmat, is just making sure that they understood our alternate PPE. So try to limit cross exposure between crews, patients, and hospital personnel through social distancing. So we really want you, when after you've moved the patient, is to move the ambulance or the rescue unit out of the bay. I've been by a couple of hospitals in which there are a bunch of trucks lined up, and there's going to be no social distancing on patient transfer for those cases. So please try to do that. We do know if you're bringing in a trauma alert or something like that, you're not going to get back to the truck right away. But we really do want you, as much as you can, we've asked each hospital to give us a decon area away from the ambulance ramp. So on transports for direct admits, we're going to continue to bring them directly to the patient room. That helps us get the patient transferred more quickly and is low risk. For isolation precautions, though, we are going to transfer those at the ambulance ramp. Post-call after decon, Please make sure that you're fully decon before you go back into the hospital. And there you can finish your report, wash your hands, use the restroom, following the hospital restrictions or screening procedures with courtesy. We're going into their house. So post call, we're not to be in PPE except for the surgical mask if indicated. For non-emergencies being transferred out, we're having dispatch call to the floor 15 minutes out and then transferring the patient out at the ambulance ramp for hospital discharge. For the special transport teams, All Children's, Aeromed, Bayflight, St. Joe's, Sunstar Critical Care, Mental Health Transport, CCPs, is we're going to transfer those directly from and to the unit that they're coming from and going to. We don't want to impact good patient care on those cases. So overall, it seems to be going pretty well with hospitals on transfer of care.
Get a couple of questions while we were talking about that, which is if Baycare is requiring surgical masks, do they have those for us? Because we don't have a lot of those. We have procedure masks and N95 masks.
Yeah, so they are giving a surgical out. I know that Baycare is, if need be, and we might as well just say thank you and let them give them to us. I would say that multiple patients getting sick in one nursing home, Dr. Cho, Dr. Jameson, Gail Guidish, the Assistant Director of Public Health, and I have had conversations that we really want to be very proactive. Some of these cases that you've seen across the country is not something that I'd want to see happen in our county.
Yeah, the initial, and those discussions are still ongoing, but the initial plan is to have a strike team respond and assess the situation. So Stephen, greatly limit the use of neb while in yellow. Yeah, so avoid if at all possible in yellow. If you've got all your PPE on, the full thing, and you absolutely need to do it and there's no other alternative, I wouldn't 100% prohibit it, but I would really say try to avoid. Once we go to red, it's prohibited. We can't be doing that when we're in condition red. All right.
Oh, while you're saying conditions, keep in mind that the hospital status screen will always say the current condition, and expect that the world is really changing. You'll get multiple notifications if we go to red. So once in a while, somebody will get confused and go, "We're already condition red." No, we're not. You'll know it when it happens.
Yeah, for sure. All right. Next is the care protocol. Again, this protocol will not be live until sometime in condition red. So please do not think that we can do this right now. This is not where we're at right now. This is in preparation for condition red and or condition black. This is for use in shared medical decision-making with a confirmed or suspected COVID-19 patient to determine who can stay at home versus go to the hospital. They must have all of the inclusion criteria. They cannot have any of the exclusion criteria, and you really need to go through this carefully with them. If they meet non-transport criteria, but they really want to go to the hospital, I would involve the online medical control physician in the conversation. Obviously, if they don't meet criteria, they really should go. Verbal consent will be taken by one clinician and witnessed by another. The signature is called crew signing stay at home, and the second clinician does the witness on that. And that's, again, so you don't have to hand your EPCR to the patient. If we do this, you'll see at the end of this packet is a almost akin to like a discharge instructions information sheets that we would ask you to hand to the patients as well. And the last one here, I'll just briefly mention that this is supposed to be a guidance document to assist each of the agencies with best practices, and maybe ask Chief Cepetto to walk through it.
Sure. So we're as part of the working group for this. Basically, again, this is not to replace anything that you currently have as part of your protocol, your certain department, specific department. This is just to help fill in any gaps or help guide. So don't think of this as the end all and be all. This comes right from the CDC. Everything that's currently out there for the CDC, we've been waiting for new guidelines to drop for 3 weeks now, and not happening yet. I know as soon as you hit publish on this, that's when they'll drop it. But not happening yet. So yeah, this is just the exposure guideline from the CDC. So you've got your definitions, DICO, what a control officer is. So COVID, one of the big things that we took out of a lot of the communication back to us was that we didn't understand what length of contact and what exposure really kind of meant, what close meant, what distant meant. So we put those in there very specifically at the 6 foot, what a brief interaction means, what a prolonged exposure means. I think we're kind of all getting it now, but in the beginning, this was very confusing. So that's what we set out. And then there's still a little bit of confusion out there. So hopefully this helps clear that out. The classification of risk, this is a really kind of a big one. High, medium, and low. That's where the CDC is right now. These are the kind of things that were expected to change over the past few weeks, but we haven't seen that yet. So this is still in play, high, medium, and low. It takes into account that exposure level, that exposure time, and how close you were, what you were wearing, and what the patient was wearing. One of the biggest things that the CDC recommends is that the patient wears that mask, as Doc has been saying since the very beginning. Get a mask on that patient. So that is a big deal. So this takes that into consideration. So we'll move down a little bit. It kind of gives us some examples of what a high risk is, what a medium risk is. I mean, again, these are just examples. You have to apply them. So determination of work status, again, another really big deal for every, what do we do? I broke the 6 foot barrier. What do? I got to go home for 14 days. I have to quarantine. No, that's what this is trying to help eliminate. We used a study to determine what the incubation period was. That mean in there, it helps justify what we're doing, what the CDC is doing. Again, all out of the CDC. So that's what those categories, those definitions of those categories are. That incubation period there, that's what we're referring to. Decision to go back to work. These are decision to go back to work can be based on if it's a known COVID patient or a not known COVID patient that you're waiting to get a result back from a test. That's one of the big criteria in separating those two. So a high, low, and medium categories, all of them, the CDC says that for up to 72 hours, you can continue to work. And again, this is department specific, what they want to do, but you can continue to work up to 72 hours for somebody who we don't know is a positive COVID. If they are definitely positive, that changes the game. So that's what that means. And then where to get tested. So as I think the doc told us last time, that they've now worked it out, so we do have a site, and which is good. And this is going to really streamline some things. We've got the numbers in there, and then the procedure, and it works. So that's all in there for good information and for references. The isolation order comes into play along with where to get tested, and then who to contact, and kind of what those guidelines are there. And then for reference, that chart right there is from the CDC, right out of the CDC, and that is basically everything we just talked about. We just took that and we put it in words. And then there is a exposure guideline. Down at the bottom, it's a little bit of a flow chart. Again, it starts off, was the patient wearing a mask, a surgical mask? That's the biggest deal. If it's yes or no, you go down from there. That's pretty much what I got.
Thanks, Chief. Okay, so that is really the last specific document in here. We do have the instruction sheets, which we've shown you before, and I'll throw that up again, remembering that the stay-at-home protocol is not authorized for use yet. That would come at a later time as things ramp up. And so this is the information sheet that you would do with the patient if after your shared medical decision making, you would decided that together that they were going to stay home. This side has some of the criteria to make sure we've done the appropriate screening on them. Obviously doesn't replace our full clinical tool, but this is just noting a few of the things that we assessed when we were there. How they should monitor their symptoms and care for themselves, how they should protect themselves and their family members, when to call 911 back, again, basically just looking for hypoxia, and then all of the community resources that they could access after the fact. And so that
one soapbox there, Doc, from me is this is not a refusal, and it is not a paramedic-induced refusal. This is a shared decision-making to remain staying at home.
Yeah, absolutely. Josh says, do we have a plan if there's a nursing facility that requires evacuation? So we've done that before. A couple of you guys may remember when we evacuated a hospital in the middle of the night a few years ago. That was fun.
Yep.
We're okay at that. I think we did a couple of nursing homes after the last hurricane when they had no power and bad conditions. So we do have a general idea of how to do that as far as destination for those patients. That would maybe be one of the real stumbling blocks. But if we get to that point, we will have some folks there, like I said, as a strike team to help manage that. Those conversations for the exact details of those plans are still going on actively right now. So I don't have all the answers on that for you.
Yeah, let me give one more thing there is that when DOH starts to see a patient or two, they let us know. And then from there, we're sharing the pre-plans for the building. And that way, can we socially distance or can we move people to a different wing? How fast do we need to operate? One of the things interesting to me is almost all ALFs are less than 25 patients. And we do have some large nursing homes with a couple hundred patients, and there's not much in between. And so I think the preference would be, if it's a small home or something, we're going to get in and get out quickly. And then if it's a large facility, can we use different wings to try to separate HVAC systems, things like that?
Yep. Okay. So I see, can we possibly get a couple extra surgical masks for non-RIP patients? I'm not sure that we have the supplies to support that. So when they stay at home, we don't get a refusal signature. No, you do a verbal refusal with them and you sign the crew signing COVID-19 stay-at-home signature, and then that gets witnessed by the other crew member. So the point is that you are doing the consent with them, but they're just not physically touching your EPCR. And Josh says, can we use that type of refusal signature for current RIP patients who want to stay at home to prevent contamination of the PCR? That's a good question.
Yeah, we did add back, we had taken it away because it became kind of a bad habit, but we did put in unable to sign contaminated patient back in the signatures.
There you go. Chief Tedesco says, what about treatment strategies, chloroquine and hydroxychloroquine and or zinc? So there's a lot in the news and in the media and all that recently about treatment strategies. As I mentioned earlier, we are exploring the ability to get a small stockpile of hydroxychloroquine to have in the county in case we need it. But again, that's an unproven medication at this point. So we're trying to see what we can get, but most of our hospitals actually on the hospital call today said that they have at least some of it in the hospitals. Zinc, I think, is a fairly well-established antiviral, so that's great. Obviously, there's some complications you can get if you take too much zinc, so just keep that in mind. Julie says, please make sure you are not signing for the patient. And Josh says, will the paramedic assistant stay at home? The shared medical decision-making for staying at home apply to the nursing rehab facilities. So I don't think that it would necessarily apply there. That's more for people out in the community. Most likely the staff at the nursing facility is not going to be excited about you leaving a COVID patient there. I would imagine. Okay, so let's go on to Jasmine talking through the EPCR stuff real quick. Is that okay, Jasmine?
Yeah, that's fine. Let me share my screen real quick. Got it? All right, there we go. All right, a few updates on EPCR. Just two things really. We've added new impressions for COVID. There's 3 of them, and that we'll go over where those are. And there is now a wizard making it easier to do your standoff assessment, so you can document that in your EPCR as well. All right, so when you start up, you're going to see what's new in EPCR. This will come up. Just make sure you take a look at that. That'll give you some directions. All right, so under objective impressions, you're going to use your primary assessment the same as you are right now and put your primary impression of the patient and any COVID patient under your secondary impression. You need to pick one of these 3. Under chief complaint, you'll see the standoff assessment, and under this one click, it will open up and you'll have the full assessment. We're doing the standoff assessment there. Sorry, I'm not driving this computer. All right, here's what pops out once you click. And then just like any other intervention, you're going to go through this and answer these questions. Pretty much the 2 big changes in EPCR right now. Anything else to add? Okay. This is just going through each one of them. Any EPCR questions? I don't see any right now. And that's
Okay,
it.
sounds good. So the plan is for a medical control directive shortly with all of this information, as well as probably an updated copy of the pandemic plan for you all to see. That hopefully will be out before too long, and then we'll get assigned tomorrow morning in Target Solutions. Dave, I think it's going to go up tonight, but I'll double check on that. Jasmine, is that the plan?
That is as soon as I get the document, it will be posted on Target Solutions.
They will be hot off the press when they go. And Adam says, are we getting field thermometers to answer the 100-degree question? No, we're not. They're not accurate. We can't get them anyway. And so fever is a fever subjectively the same way it always has been.
We did try. We got a whole bunch of infrareds, and they were like consistently 91 degrees or something. It was pretty crazy.
Yeah, my nurses hate me. I think I ordered rectal temperatures on like 4 patients last night. What are you going to do? It's the only accurate one. Okay, so anything else that we needed to cover, Chief Zeppetto?
I don't think so. I think we've done a pretty good bit there. Biggest thing is take some time, and everyone needs to take the time and go over this and really digest it, and then have it close at hand.
And Jasmine, any other thoughts or comments or issues?
Nope, that's it for now. There's going to be added training on this next week. So if you have any feedback or questions, you can shoot me an email.
Okay, Craig?
Thank you all. Be safe. Chief Magnus, if you could call Gail Tyberski. She'd like to see what you want on that screen request.
Great. A couple more questions here. Portable pulse ox.
We tried to order some, but weren't able to.
Yeah.
They're on back order.
And thank you, Chief Bessler. And we'll just stall for a second or here too. So any last questions, go ahead and throw them up. Now's your opportunity. We've been at it for a while already, so I don't want to drag it out anymore, but throw any last questions up there. And unless we hear anything else from you all, we will plan to see you again on Tuesday afternoon at our next live Q&A session. So looks like that's about it.
All right. Everybody have a safe weekend.